Oh, it's your show.
So you're the chair, right, of this?
Me?
Not so.
I think skip this. He pays for the food.
That's all. Okay, so welcome everybody. This is the CLMA sponsor Lab Task Force meeting. And thanks to CLMA for sponsoring the light dinner we have. I hope you enjoy it. And so why don't we go around the table and do a little bit of introduction. I'm Francis Chen from Hawaii Health Information Exchange.
Katie Ding from HHIE.
Karine here, Uji from DLS.
Skip Dean, formerly DLS, board member at HHIE.
Stella Lasessa from DLS.
Steve Sakamoto, Department of Health.
Keith Navishi, Department of Health.
And Jeffrey Liu at HHIE.
Tania Harris, Clinical Lab. Aldine Brown from Cortini. Susan Cross from DLS.
Raymond Young from DLS.
Welcome. And on the phone?
This is Jody Diao from CA.
Okay, so Judy, are you down into the GoToMeeting also?
No, actually, I'm on my phone.
Oh, okay. Sorry about that, but so I guess this first part was requested by, I think it was Curtis who asked about, like, you know, what is the relation between HHIE and the state and the CMS and the rest of the community. So I just spent maybe about 15-20 minutes go over quickly. For those who already know about it, I apologize, but for those who are perhaps not too familiar with the HHIE, this would be a short introduction. Okay. So again, you know, the background of why HHIE is needed is like healthcare costs. Basically, it's unsustainable. It accounts for a significant portion of the economy and state budget spending. And also, there's a lot of fragmentation going on, and then the primary care providers oftentimes do not get information that they need after the patient's visit. And then specialists also doesn't get the information when they get the patient referred. So everything is not quite working the way they're supposed to. And so in 2008, 2009, you remember the last major recession. That's when the High-Tech Act got passed, and then there was $19 billion that the federal government allocated to health IT. And basically to provide assistance and technical support to providers, to enable coordination, and also develop workforce. So they are it's a multifaceted program. And this is a picture of when Governor Abercrombie in February 2012, he basically signed a memorandum of agreement with HHIE to redesignate the Hawaii Health Information Exchange as the state entity to administer health information exchange. And then with the state's endorsement back in 2009, we were granted the ONC funding to administer the health information exchange, and we have two programs. The first one is the Health eNet, Hawaii Health eNet, or the system that we're going to be using administer the support the exchange, and then for there's the REC program, which Jeff is the director of that program, and it's to help provider implement certified electronic health records. And it's a 4-year program for the about over $10 million, and it requires $1.2 million in matching fund by the private sector. That's why, for those of you who are not familiar, that's why we ask you to sign that in-kind contribution, because the time you spend is also like value that can be counted towards the in-kind contribution. Yeah, so it's important. Then who are the HHIE, right? Who are we? And so as you can see, that the state of Hawaii has a component, then several medical centers, the laboratories, payers, Aloha Clinic MSA, and also Hawaii Health Information Corp. And then we also have like AARP and consumer groups to give us like, their perspective. Of course, Skip is now like a private citizen, so he is a very good representative of the good representative of the consumer side, right? Advocating for the consumer and the health information exchange. And then we are also active participant of the State Health IT Coordinating Committee. And in this picture, these are the healthcare transformation coordinator, Beth Easting. Many of you have met her. And then we have Department of Health representatives, the CCA representative, Department of Human Services as a Medicaid program. And of course, last but not least, the state CIO's office. They are all the state government entity that's on the Committee for Health IT, and HHIE is one of the private sector participants. And there's a couple other private sector, including like the Insurance Health Connect, the Health Insurance Connector, and the HHIE. For those of you who know who HHIE is. Okay, so as far as how we make decisions, it's always by committee consensus and guidance. So these are the different committees that are guiding the Hawaii Health Information Exchange, and then the State Health IT Council is kind of like the one who give us some guidance at a different level. And so they also participate in many of the committees. The governor's office actually also participate in the different committees. And the ones that are that I am more familiar with and have participation in are the Data Access and Management Committee, the Technical Infrastructure, the Legal Policy, and then the Physician Advisory Group. But because we now are still trying to recruit a communications person, that group is like they're meeting, but it's in a slightly different way, not like the open meeting like this, as far as I know. And so you may ask, where does the Lab Task Force fit? And I think, and correct me now, the board members in the room, I would say that we are somewhere between the data access and management and technical infrastructure, right? Because what we are trying to do is to help implement the standards or clarify the standards and implement the standards in the laboratories and the hospital laboratories. So, and it's in support of the Department of Health as well as the ONC. So, for those of you who might have seen this before, this is the state health IT plan that was released sometime around maybe, I don't know, sometime last year, maybe about the summertime. And in there, HHIE is a component that is basically one of the master provider directory, the master patient index is part of the HHIE function. And we are basically the conduit between the private sector and the public state government. Okay, so as you can see, like pharmacies, clinical labs, and by the way, this is like generic clinical labs, right? I mean, not just particularly clinical labs of Hawaii, just as qualification. And then then there are other entities. So what do we see as basically the benefit to the state for HHIE? So we deliver critical information through the system, the Health eNet, and then we support the immunization and cancer registries. We see ourselves having a role to support the reportable labs, the syndromic surveillance, and then we are going to try to really get involved in the Medicaid providers and patients, the UTF, which is the government employee program, right? And then the public health hospitals and the Department of Health. So I think this is all I'm going to go over with as far as the overview of information. Are there any specific questions? I mean, the rest will be more like the infomercial. So I spare everybody of that, like how great we have been and all that. Any questions? Comments? Okay, no. Then continuing on the agenda, actually I should show that, but there are some that we have been implementing the direct messaging for the better part of a year now. And we have some really modest success. One of the things that we have found is that a lot of the providers are using, because of the meaningful use requirements, they need to at least do a test on the direct, and then many of them have signed on to our direct application, do the attestation, and then they kind of stop using it. And that's, I guess it's not surprising, but then actually thanks to Dean and Kokini and Steve from Department of Health, they're really finding meaningful use of the direct technology to support the public health activities. And so, Dean, you want to describe a little bit of how you are using direct as a case in point?
So we didn't have any way to communicate with, for communicable diseases, Department of Health. We used to fax them things. And we were the only ones, I think, doing that. And so it gave us a different opportunity to allow us to use the direct messaging instead of faxing. Right now we're doing both. At least I told them to do both. But they really are getting comfortable with it. So they might kind of like forget the faxing piece, which is, you know, eventually what we want to do. And now we're trying to be able to apply Snowden and Lloyd codes to the test directory so that the communicable disease reports will go via the computer to the Department of Health. But we're just not there yet.
Right. So those are going to be work in progress for the next few months, right? And so a little bit more update, like as I kind of breezed through the earlier presentation. We, as an organization, because we care a lot about the processes, so we have to have like legal agreement for everything, and so for all participants, they need to have a data sharing agreement. And of course, I mean, I didn't include any of those in the packet, and those are not really in the slideshow. Dean? Oh, okay. So did he?
I don't have the information, but I sent it.
Oh, okay. Okay. Thank you. So we have refined our data sharing agreement with the participants to support both the direct messaging and the exchange, the real exchange of information. And so that is being still negotiated with different organizations, and then, you know, when they get to actually sign the data sharing agreement, that's when they really become a full participant with the health information exchange. And to support the data sharing agreement, we are, like, for the last couple months now, actually, we've been frantically trying to develop the policies and the guiding principle, to translate the guiding principle into policies and procedures, so that we can give the reassurance to all the participating organizations that we have our acts together. But a lot of it is difficult because in many ways we don't really know about we don't have a good understanding of the technology that we are deploying yet. I mean, I hate to admit that, but because this is something that is complex, it's new, we are still learning it. So while we're learning it, we have to develop policies to support the operation and the use of the functionality, and that's where the difficulty comes in. I mean, if you really already know your operation, know your system, then developing policy is much easier, but in our case, it's a lot more difficult. Plus, we have to make sure that it's acceptable to the whole community, so that makes it a little more challenging. And we've been, so like as Aldine mentioned, we've been trying to develop the interfaces from the hospitals and the participating organizations to the health information exchange. And with the two lab companies, DLS and CLMA-HHIE, they are very close to being ready. And then so as soon as we get the data sharing agreement signed, then we'll be able to turn on the interfaces and start making lab results available to participants in the health information exchange. And actually, I should bring up this PowerPoint for illustration. So as you see in this slide, I mean, from the state's perspective, the Health Information Exchange, the master provided directory, that's the directory for all the physicians in the state. And then the master patient index, that's the patient identification module that we're going to be implementing. And so what does, I mean, why is that important? I don't know if I need to explain that. For those of you who deal with patient day in, day out, you probably know that it's a major undertaking to try to identify a person from different sources, like from the doctor's office to the hospital to the labs and maybe to the pharmacies. Like, I mean, everybody has slightly different information. Some organizations capture more information than others. But when we try to tie the whole medical records together, that is not an easy task, but that's what we are trying to do as a key component of our activities. And that is going to be one of the first stages of our phase 2 activity. Okay. So is Susan on?
Susan Naka?
Yeah.
Yeah. I didn't hear. I didn't hear.
Hey, Susan.
I thought her last night she was going to call in, but
yeah.
Yeah.
Can I check the number?
Huh?
Can I check the number?
Yeah. Well, I mean,
the published number, Francis?
Jody managed to get in.
Yeah.
That's the published number.
You want to take a roll call? Can we take a roll call? Who is on the line now? Conferencing in?
Jody Liao.
Hi, Jody. That's anybody else?
Tell us which number she called.
Yeah, Judy, did you dial that? What number did you dial? Was it the number on the?
1-877-739-5902.
Okay. Yeah.
Oh, I heard another incoming. Is there anybody else who just joined?
Hey, this is Dean, Waianae Comprehensive.
Oh,
Hey.
hi, Dean.
Hi, everybody.
Hi.
Yeah. Sorry, you missed the part that you asked, and I said I would clarify. So I just
Of course. Yeah.
You're out of luck.
Send me a flow chart.
Okay, I'll send you something so you can read through it. Okay. But unfortunately, Susan is not here because Susan is, as you know, is a representative from CLEAR, and there has been actually from day one a lot of uncertainty about how lab reporting through HIE, you know, how does it match or how does it conflict with the CLEAR guidance. And so from 2011, we've been kind of working through some of that. And of course, I mean, you know, this is the whole health IT, the health information technology has been a work in progress at both the government level and at the private sector level. And so I wanted to have Susan give some update about from the CLEAR side.
Princess, if you have her number, do you have her number? I'll call.
I don't have the number.
Can I get it from
I don't know that we have the number.
in our contact? Have it?
Yeah. Do you?
I don't know.
I didn't have it for the
Yeah.
either.
I hope she didn't, like, you know, I guess because the first agenda I sent out said the 17th, I hope she didn't get mixed up.
No, she knew last night because we had a meeting last night.
Okay. Well, maybe we can move on with, well, actually, maybe we can have Dean and Steve, I mean not Dean, we can have Keith and Steve talk about the public health reporting side, other than me being the monologue all this time and talking about law and lace. Maybe you can like give a bit of the perspective about the public health reporting, because I mean, I think that would be quite a bit of discussion and clarification.
Okay. Well,
Yeah, I'm pretty sure.
Okay.
I have her work number.
Oh,
You
that's probably,
Do you think it's on there?
okay. Well, like Francis was saying,
92,
this process of
724.
74.
MU and Lincoln Snowman is very complicated. The Department of Health has been using electronic records since 2005, so quite a long time, and still we find difficulties in administering, managing, and even configuring. So it is an ongoing process, even for us. I guess the big thing for us is moving to the standard messaging, which is Lincoln SNOMED. Currently, it looks like Kuakini might be the first hospital that's doing that for us. And we've been working with Aldine and their group, and they're actually using the same integration engine that we are, Rhapsody Orion. There are some good sites that's being sponsored by the federal government that I really, think everyone can benefit by going to. One is the Lab Interoperability Cooperative. I can send everybody a link later on. But in that website, they have all like the SNOMEDs, the links that you can download. They have, it's more like an education thing that this group has been funded for, I believe, a 2-year program, and the main focus was to get all the hospitals and labs, at least education-wise, with documentation and, at least coordinating webinars for people to get more comfortable with Lincoln SNOMED and how messaging is completed through the entire cycle from developing, transporting, and even, working with the receiver, which is the DOH or HIE. CDC is also sponsoring a technical assistance program open to all of our state's commercial partners, which is the labs and hospitals. You would have to submit it to the Department of Health. Some of the things that they've been working with the other states have been like switching codes from no code to Lincoln SNOMED, also getting the systems to be able to reportable filtering, HL7 construction messages, and I believe they've done about at least 8 states so far. So I think I sent out emails to all the labs IT managers. So if you guys are interested in that, just let us know. We'll give you a TA request form, and then we can review it with you folks. And if you want, we can send it to the CDC. CDC will do it remotely with the labs, for your help.
So did any lab actually submit the TA request to you?
Only we submitted our own. No one else has.
And
that lab information interoperability, that slide that you have right there, that's an excellent site. I went to a webinar this morning, and I find this group has the best material as far as documentation. Just to see LOINCs and SNOMED, how to download it, what is the best practices, all that kind of stuff that you would have to know. And it gives real life scenario, and they don't tell you that it's easy. They tell you that it's hard. you're going to need, and what kind of personnel, what kind of people you need to actually work on this kind of project.
Yeah, so I mean, I don't know whether you want to go over this, or we will probably just distribute it to everybody.
Yeah, I can send an email off to everyone.
Okay. Yeah.
It's a very, and I believe the seminars are ongoing right now. So when you go to this link, you're going to see live webinars that you can actually sign up for. And it's a group from the entire United States. Log on, and then you can see all these sites, and they go step by step, answering question kind of thing.
Is SNOMED confined to pathology, anatomical pathology, or you're also looking at clinical laboratory reporting with SNOMED as well?
Yes. Because for our end, basically the LOINC is like the question. LOINC asks the question of the test. The SNOMED gives the answers. So we're going to need a question and answer.
And you're looking at mostly for organism microbiology, SNOMED on microbiology. What's
right?
Oh, okay. So it's not for all. Well, I guess all reportables are communicable.
All reportables, right? Whether it's microorganisms,
okay.
antibody tests. So, like for Kokini, we gave them a list of what we think that they're going to come up with. Because I guess it's difficult to come up with.
Actually, I have the list that our team shared.
Oh yeah, in fact, that's the list we gave to them.
Yeah. So just for clarity, can everybody see? I guess it's going to be difficult. I can somehow, I don't know why. I can make it bigger, so apologize. But basically, now these are disease conditions, and it looks like you're trying to use like some generic form.
Yeah, that's the SNOMED.
That's the SNOMED side, right?
Wait, so what they were doing for the microorganisms was they were passing us the result description, but we told them we actually needed a code for that because labs might interpret their descriptions differently. We need to have a standardized code in there so we can interpret it.
Okay, so are you suggesting, Keith, that this list is available to everybody, and you want everybody to, if they choose to, for the SNOMED mapping, that they can use this list basically to report to you for the mapping?
Well, I'm going to have to download the most recent list. This is just a list that was on my computer that we was working with cooking.
Yes. This is only about 109.
I believe it's 900 something.
The
976. Loins are 61,000.
900. Okay, so it's 900 something.
Yeah, so it's like I said, it's not an easy mapping from loins to locals.
So how did this list? How did you come up with this list?
I used a list from CDC, but I used my own interpretation off of the disease names that we use and the descriptions. Kind of matched it.
Okay, so again, to clarify, this because you develop it from the Department of Health, if everybody choose to do so, you will accept that they basically map the SNOMED code using the one that you have provided?
I'll probably update it eventually.
Yeah, I mean after you update.
Oh, yeah.
Okay, so that's good news.
Yeah. Because what Kokini was doing is they was putting the result description in the OBX segment, but they were missing the OBX5, which is the true SNOMED position. So that's why I needed to map the description to the SNOMED code that they're supposed to put in the OBX5. That's what they're missing.
And then just let me explain. See, I'm the lab manager, but I'm not an IT person. But it's my job to do this. So I needed a lot of help.
Yeah, it's a lot of help.
And we have an IT department, but it's for the hospital. And although there's one med tech on it, nobody knows anything about LINC or SNOMED. So it's been really hard for me to be able to establish what I need in order to get accomplished.
Because I think it's good that, to see if you can use the CDC's technical assistance, because that's one of the things they do. And it was actually estimated that it takes a full staff about 800 hours to do just the loin mappings. It's a very difficult.
It's very
it's not something that can be done quickly, and it has to be accurate estimating. Because if it's not accurate.
Ray, wasn't there a pilot project?
Yeah, there was an initial effort that we kind of worked together.
For the
That,
80%.
we can talk about that.
yeah, that will, yeah, if that
We can talk about that
item, yeah,
after we finish with
we can report the status.
public health reporting. And so, you will get a hold of Susan?
I left a message on her.
Oh, okay. So for whatever reason she can't join, so that's
I don't know.
unfortunate.
Something came up, or
Yeah.
she's usually very reliable.
So actually, again, so once you do the update, you will distribute that list to everybody, and
I just want to confirm it with the CDC first.
really confirm.
Yeah, because that's what I put in my technical assistance. I want to make sure that what I have conforms to what the CDC is asking.
Actually, something similar. Last week I was in Washington D.C. for ONC meeting, and Massachusetts actually has done what you just described. Like they did the mapping, and then their labs who I need to report, they basically have already like a template of codes that they just select, and then they save a lot of effort in that process.
Massachusetts has been lucky because the state has mandated the labs and hospitals to make it so many years ago. So, like for Hawaii, it was never really mandated. It's like we always have to use local codes.
But now the driving force is actually meaningful use stage.
Right. So now it's meaningful use, right?
I mean, everybody knows what meaningful use stage 2 is, right? So we don't have to go over that. Yeah. And so Raymond, that answers your question, huh? That you were questioning whether the TA will apply for the. I mean, not the TA, the Massachusetts, whether it was for everything or just for the reportables. Yeah. So by the way, I guess, again, I would imagine that the CDC support will only be applicable to the tests that are for public health reporting, right? That are appropriate for public health reporting, and not for general loin mapping.
I'm not absolutely sure. You just said TA for mapping local codes to standard vocabulary, routing, transporting, HL7 creation, helping with the lab information systems.
I think it doesn't hurt to apply. Yeah. I mean, I think it's best to try and see if you can get assistance, and if you do, then that'll be great. So I don't think we should hold back and not, try to put it in.
Yeah, because earlier, Kaiser, Lynette Akiyama from Kaiser called me and asked, because then when I raised the question about the SNOMED, and she wanted to get clarification also. So I guess thank you for clarifying how that's going to be used.
What is the extent of the assistance? Is that mostly advice, consultation, or do they actually have resource to support?
Well, apparently they designate resources out, and of course it's not mostly remote, but they want to come to Hawaii. But they said mostly remote, and apparently they did several states already, and apparently they're quite good at it. So that's why they're offering it to all the states now. I can give you some documentation what they do.
Yeah, please.
And I'm sorry, for me, the form was very confusing, so I sent it to Francis. So, I mean, I think you probably need a Raymond background in order to put
no, but the
form out.
The form itself is not.
It doesn't say that much.
Hello, someone just joined the call.
Yeah, that's me, Susan Naka. Sorry.
Oh, hi, Susan. Thank you for dialing in. Yeah, we kind of jump ahead a little bit, and we just talk about the electronic lab reporting criteria, especially with SNOMED, because that is something relatively new to everybody. Because I mean, for the last year or so, we talk about loin, And we actually did some pilot with it, but then we have never really delved deep into the SNOMED, and I'm glad actually that Keith, you have taken the initiative and have the foresight to get it all ready for everybody, for the lab community. So kudos to you for helping on that. So Susan, I requested that perhaps, like, maybe for this meeting, again, we have representatives from clinical labs, from DLS, from Kuakini, from Y9, and from VA, and also, of course, HHIE and Department of Health. So would like to hear from you any news, any new development, or anything that we have to be mindful of from the CLIA perspective as we try to make, like, try to work with the labs to have them leverage the State Health Information Exchange for the results delivery and communication. So please take the floor now.
Sure. Well, first of all, is Andrew Chu there from Department of Health?
No.
No, he's not. He's not here yet.
Oh, okay. Well, the reason why is I kind of rushed out of the office because I was on Maui today, and I didn't bring certain things. So anyway, I'll try my best. But I'll kind of retract what's been happening as far as who can, well, the clinical lab test results, what laboratories can, who the laboratories can release clinical lab test results to, because that's kind of where we are, right?
Right.
And so I think on the state side, with that harmonization bill, it essentially says the labs can give test results to the provider and to any HIPAA-covered entity. That was the last on the harmonization bill. That preempted anything, other rules that we had in our Chapter 110, or essentially Chapter 110. What I was trying to find that bill because I wanted to double check whether it also meant patients were allowed to access their lab test results. Anywho, whatever it said, there really are no state barriers on, other than it's got to be the provider, the private provider who orders the test, and any HIPAA-covered entity. Whether it also includes patient, I'll just throw that in for now. There are no barriers as far as the state. However, the federal always had in their CLIA regs, and it's been clarified this past week because I asked them. It says, yes, test results can be released to the provider who ordered the test, or any other entity who is responsible for using that test, including the patient, as long as it's indicated on the test requisition. So there still needs to be some kind of written or, albeit electronic, communication from the provider who ordered the test on who can get the test results. That's kind of how it stands right now. Waiting in the wings is the CMS and DHS, CMS rule, called right now CMS 2319. And it kind of also opened up in that that addressed the fact that patients can now ask for any lab results directly to the clinical labs. So irrespective of whether the provider said patients could have their test results, this regulation would allow patients to request for their lab test results directly to the lab. And it will be a HIPAA kind of procedure. That hasn't passed yet. We thought it would be passed and adopted by end of 2012, but it hasn't been finalized yet.
Oh.
That's Susan, that's a rule, right? Not a law.
Yeah.
Yeah.
That's kind of where I'm getting kind of. Yeah, it's a rule.
Yeah, it was published in the Federal Register for comment, right?
Right.
This is Skip.
Mm-hmm.
Yeah. As far as the harmonization bill, as far as I understand, it does not overturn any existing rules or regulations. It's just that basically it's trying to use the HIPAA as the basic standard, and if, like, for providers or covered entities who, as long as they abide, they are compliant with HIPAA, then they are deemed to be compliant with any of the privacy laws that apply in the state, but it does not, I don't think it addressed specifically about the administrative rule in the laboratory, in the Department of Health, the administrative rule that governs the labs in terms of patient access to data. And so I guess if and when the clear guideline comes out, then I'm not sure how that is going to be addressed from the administrative rule perspective, whether we need to have like an amendment, like how when the HMSA attempted to introduce that bill a couple of years ago to specifically address that piece of the administrative rule.
I read in March an article from NIR, the National Intelligence Report or something like that, for the lab, that by late summer there will be a finalization of this bill where 30-something states out of the 50 will actually pass patient access to data, and that's pretty much imminent and probably a point of no return at this point. But there's still probably some debate going on in the Fed level, on the Fed level.
Right. So we don't know how it's going to be formulated, but yeah, I haven't seen the final. They just a proposed rule went out, and the intention. I don't know whether it really affects. I don't know how it's going to affect the HIE, but patient access now is going to be open. So no matter what state restrictions have, the federal will preempt them. And that's kind of when I read the harmonization bill, it removed, it's what I would say was it preempts any other state regs is that it removed any barriers that all state agencies had as far as where clinical lab test results went. And that would be just HIV programs, other health programs within the health department. So that was the intention of the harmonization bill.
Right.
And so I believe then, and it essentially, I believe, that's kind of why I'm really sorry I don't have it in front of me. I believe it said authorized person now includes the provider who ordered the test and any covered entity, because it wanted to incorporate how in our Chapter 110 lab results are sent to only the authorized person. So if they expand that authorized person, that's kind of how they wanted to include HIPAA-covered entities.
Susan, wasn't that the HMSA bill, not the harmonization bill?
Yeah, okay. That's kind of why I wanted to see the harmonization bill in front of me.
Because the harmonization, I don't have it in front of me either, but it basically just accepted, as I think somebody said earlier, just that HIPAA would be the standard as far as dissemination of data, and with no specific reference to any specific law and or any specific rule, administrative rules. That's my recollection.
Yeah, now that I think about it, you're correct, because there was the HMSA bill which expanded the definition of authorized person, and then the harmonized, and that one really was just directed to clinical labs. It didn't include other health department agencies.
That's correct.
And so the harmonization bill then affected all health department or state agencies. And so you're right, Skip. It simply said clinical lab test results can be released to, and it listed provider and HIPAA-covered entities. I don't don't know whether it says may or will be released. So, yeah, that's kind of why I wanted to bounce things off Andrew. Irrespective, I mean, to me, oh, go ahead.
No, you finish your thought. I just had another question.
Well, irrespective of what our state regs are, I think any barriers to having test results go into some kind of information exchange, I think it's going to be removed. So how, the only thing that I really need to clarify with CLIA is, does it still require a provider-directed instruction somehow?
And that's kind of my question. You know, when we spoke the other night, I was thinking more about, you know, that restriction that seemed to be in place. And as I mentioned the other night, could that be included in some kind of data servicing, DSA?
Data sharing.
Yeah, data sharing agreement, and maybe even the notice, the HIPAA notice to patients that their data would be shared, you know, appropriately and, you know, under HIPAA.
I'm sure
without you know, because I think you recognize, you know, for any laboratory or any physician, or from the lab's point of view, to expect that every physician is going to write not only that he wants results, but he wants Dr. Jones to get the results, Dr. Smith to get the results, you know, as opposed to any treating physician. You know, again, I think that's a barrier that, you know, we'd like to remove. Either through, go ahead.
No, I agree. That was the whole purpose of the information exchange, to allow anyone who is involved with the treatment of a patient to have access to all necessary data. And certainly, you don't, to have the primary caregiver say, no, I don't want it to go to somebody, you know, might eliminate or just defeat the whole purpose. So I would say, you know, everyone is trying to remove those barriers. Now, how it's going to fall and how it's really going to happen, and even CLIA says they are working on working out that part of it where they're saying it has to be a written instruction on a test requisition.
Right. See, and again, just from my perspective or my opinion, you know, just as we discussed with you know, the CLIA folks a year and a half or 2 years ago, you know, that one barrier that Gary identified, having to do with the responsibility or liability of labs putting lab data into the exchange and then being responsible for what happens with that data. And I know that was addressed. And I'm thinking, and I think our position here in Hawaii was that, you know, we're not the only people in the world that are trying to accomplish the same thing. And obviously other parts of the country needed to deal with the same issue, and it was dealt with. And so I'm thinking the same thing with this new obstacle that seems to be in our way, having to do with, you know, specific mention of other physicians or treating physicians on a requisition. You know, that's a barrier for us, but again, it's a barrier for California, for Florida, for Utah, for Montana. So, I mean, I kind of expect that, you know, the CMS people and the CLIA people will, you know, resolve it, right? I mean, I don't think, you know, I guess all that I would like or appreciate would be for you and Gary to, you know, stay tuned in and let us know, you know, whether the barrier is removed or whether the barrier is, you know, still there.
To some extent, that is not too much of a concern because of the technical functionality of the portal that we are building. The way that name of the portal is the Pro Access, okay? Pro Access. So what happens is that when data from the lab flows into Pro Access, that the the patient results will not be available to everyone automatically. I mean, it is available now. I mean, it will sit in the what we call the data stage or the repository of the particular data contributing lab, okay, for lab results. And then for the physicians, whether it's ordering copy to or attending or some other physician that has association with the patient, they will have access to that particular result. But for physicians who don't already have an established relation with the patient at the time of order, they will have to, number one, be authorized by the HIE as a physician, and number two, or that the category of user who can access patient results to begin with, right? And then the second caveat is that if they need to access the result and don't have a previous established relation, they will have to use the so-called break the glass function. So they can see that from the community master patient index that patient exists with some information on the HIE. And if they say, okay, I'm treating the patient because the patient happened to walk in my door and now I have an appointment and has something that I need results for, then the physician can break the glass and establish a relation with the patient, whether it's a one-time or whether it's an ongoing relation. And that becomes an auditable transaction on the HIE. And so in a sense, from the procedure standpoint, and we are working on the detail for the procedures, is like, will the labs want to be notified if something like that happens? If you're the data contributor and you have your data in that repository, and then some other provider broke the glass and retrieved that information, and of course they have to give a reason why they're breaking the glass to begin with, and then if it's going to be logged in an audit log, and then the labs want to have access to that audit log anytime there is someone that who breaks the glass on their data, so to speak. And then then I don't know whether that would do anything to help or not in terms of building up the confidence that it won't be just misused indiscriminately by anybody who happen to have access to the HIE.
I think as long as, and that's a good explanation, and maybe that's what other systems, whether it's the HHIE or other states, but I think as long as the liability of passing the information or the information being passed to a non-ordering physician, a non-CC physician, as Susan kind of outlined, as long as that's not borne by the laboratory, contributing laboratory, then I think that's fine. And maybe Susan, we'll hear more about that, but maybe a lot of that explanation and authorization could be included again in that DSA or some other arrangement.
Susan, categorically, does it mean that no matter what lab results, whether HIV or results on a minor, those are all inclusive and protected under this particular, I guess, set of rules and laws that are being in place and will be in place? As far as sharing of HIVs and other lab results, as long as, I guess, if we look at harmonization, it does not really pinpoint lab results for HIV or any lab results for minor. But it does address some behavioral mental health and that kind of stuff. And I don't really know, let's say if there's a lithium level, does it mean that, that's part of that? Or what in your purview is the scope or is lab results being from indirect provider not knowing particularly much about the patient itself or herself or himself will be immune from any of these scrutiny because we don't really know status on the patient, whether it's a mental health patient or not in almost all cases.
Okay, this is kind of why I need to do a little bit more. Okay, at the state level, all right, you know, we have different programs. There's the alcohol abuse, all of that, and each program restricted the information that could be released to who. All right, so the harmonization bill, as I understand it, removed all those restrictions on any kind of clinical lab test. And it says they can now be released to the provider who ordered the test and any HIPAA-covered entity. Okay, and that's at the state level.
Right.
And Andrew was very, very involved in the putting together of the language for that harmonization bill too, Susan. I think you know that too, yeah.
Yeah, and I haven't
very
really
helpful.
gotten to, yes. So I mean, and then the narrative that went along with that bill explained what kind of tests or what programs it was affecting, and so you know, all I can say is that's at the state level. Now I don't know if the federal, and that's kind of why I have to say, well, the next highest level that clinical labs need to abide by is the CLIA. And right now, CLIA says test results can only be released if the provider so designates it to someone. I mean, how that person designates it, you know, that's kind of why Skip's thought, and I think Gary Yamamoto said that probably will be the way, where there's some kind of prior agreement with the provider who then agrees that all lab test results that he or she orders will then be put in some kind of information, you know, storage area. And from what Francis, you're explaining, I mean, it sounds, I mean, that really kind of relieves or addresses a lot of the concerns many people have about, you know, having this information open for a free-for-all, and anyone claiming to be a HIPAA-covered entity can just ask away. And I think that is not the intention, and so and this is a nationwide, you know, it's at a federal level, so I'm sure you're abiding by all whatever guidelines the federal people are saying. And so all of these questions that you're bringing up, I think it's going to have to be solved at the federal level. I mean, because as Skip and Francis said, it's common to everybody with trying to set up a information system.
Yeah, I think our belief at HHIE and with the harmonization bill that it was to basically, because in many respects the state of Hawaii was more restrictive than the feds. And so the idea was to basically standardize and streamline some of the specific restrictions in the state of Hawaii through the harmonization bill. And again, it went through various revisions and input from, you know, basically all the stakeholders, you know, mental health, HIV, Department of Health, hospitals, payers, whatever. So yeah, I think we're on track. It's just, you know, we're you know, Francis and the HHIE guys are trying to understand everything that's going on with the medicity system. You know, obviously the feds are still trying to work out some stuff, and then there's still a lot of communications with the physician community too. So, and then here, you know, us guys in the lab, you know, we're kind of, everybody wants lab data. You know, because lab data is the main thing that people use to diagnose and treat. And so it's incumbent upon everybody to clarify and to give us the right processes and procedures so that that in fact can happen. So that's my opinion.
Yeah, and I think there's kind of two issues going on that's overlapping a lot. The HIE was, or information system, was meant to share medical data for the treatment of the patient. It didn't always include, the patient part of this too. So that this CMS 329 or whatever that's supposed to be finalized now opens the door where patients can now directly access or ask for their lab results from clinical labs.
I think from the HHIE standpoint, I mean, I'm a consumer, and I guess that's what I represent on the board, but that isn't the main impetus with HHIE is to address that. We understand that the public want access to the records, but that's not the driving force. We just want to make sure that the treating physicians, you know, can get and use the information. Now, how it plays out as far as the patient, I think the consumer, you know, is whatever happens, you know. Yeah. And hopefully it doesn't impact negatively the lab.
Actually, the ONC is pushing heavily on allowing patient access and for HIE to support that. But of course, I mean, from the HIE perspective, we have a hard enough time lining up providers and supporting them at this point. Then patients, yes, we do want to be able to support them, but it's perhaps a little bit lower priority at this time.
Just a few years, I think, yeah.
Well, yeah. But as ONC funding runs out, then we don't have to push by them anymore. Right? Yeah. That's for good or bad.
Mm-hmm.
Okay, thank you very much, Susan. It's very for your insight, and it's really informative. Anybody has questions or comments? And for everybody's information, and actually Susan is still on the phone, is that the policy that we are trying to develop for the HIE to support the access to information, we are really trying to focus, like Skip said, on the treatment and some payment purpose. And we really are restricting the operations exemption, like the HIPAA has the TPO exemptions, right? I mean, we are really focusing on trying to support the treatment and to some degree the payment, and trying to really avoid the operational part of the HIPAA exemption.
The payment part, I mean, from the lab point of view, and we're all lab people here, the lab point of view is I think the payment is the demographic information. You know, I don't think there's going to be any change, at least in the immediate future, as far as how claims are submitted to Medicare or HMSA. It won't be through any kind of exchange at this point, but I think all the labs would, certainly CLH and DLS would appreciate getting accurate, complete billing information so they could submit the claims. And I'm sure Cook, Edie, Castle, Kaiser, everybody, yeah. So that, and again, just as people have said, I'm on the board, and I know that that's, the board wants to be very conservative and move deliberately, and treatment is the main purpose. And again, it's also the payment, but only at this point from a demographic point of view. And as Francis said, there's a lot of discussion about health operations, but there's a lot of reservations about just opening up the floodgate. And
yeah, I was thinking about that yesterday when I heard about that, and there are some gray areas need to be looked at. Say, for example, there is one element for pre-authorization. Pre-authorization is a very hot topic, I guess, for a lot of labs, because pre-authorization of something that is really expensive that we run and not getting reimbursed down the road. Now, it is part of operations. We need to know whether it's pre-authorized before we run the test. Otherwise, we won't get paid.
No, I think that.
Yeah, I don't know whether
that's in the payment. That's,
yeah,
health operations. Yeah. Our audits having to do with peer group reviews.
Okay.
Okay. Compliance issues. Yeah.
Yeah.
When you look at the definition of what's included in health operations, it's what you're talking about, Ray, which is legitimate, is payment.
Yeah. Okay. So I mean, there's some
payment issue.
Yeah. Kind of connection and overlapping.
Yeah.
Right. Okay.
We'll take care of it.
So we are running short on time. With 20 minutes, I want to. Well, I mean, I attach a PowerPoint to the meeting, and I don't think we'll want to go over that. A lot of the information there are useful, and I think most people in this room and in the audience are probably familiar with the content of the PowerPoint, but I just want to suggest that perhaps, feel free to use the content in the PowerPoint if you need to talk to other people who may be less familiar with Loin and they need to I mean, whether it's like your administrator, whether it's to kind of like education to the staff and things like that, that may this, the content in this PowerPoint may be useful for that purpose. But what I want to focus on, rather than going through the PowerPoint, is some strategy. Like last year, we went through a pilot, if you will, where we gathered the information from clinical labs of Hawaii and DLS, who did like about 600 of their point codes. Who map about 600 of their top results close to the line code. And then now with the Meaningful Use Stage 2, there is the driver now for everybody to try to complete the whole menu of line. So I think, I just want to get a feel from this group, what do you think would be the best approach? Now, of course, earlier Keith mentioned that there may be some TA available for up to 5,000 codes, right? That is in that list for the reportable conditions, and some of them may actually cross into your general lab testing. But beyond that, how do you think as a community, perhaps what can we work together? How can we work together to make it a little bit easier for everybody to achieve that 99% or 95% of all tests in your menu being mapped to line? And I just want to hear some of the suggestions.
Well, if I may, when we initially started this project, we were thinking that if we could get 80% of the reportables, the frequency-wise, it will probably be where we can actually do a cursory look again and see where we are at and see whether we could do more. And it just seems like, as far as what we have done in our current slate of 600 that you mentioned, I don't think that we have done too much with it. The exchange hasn't started yet. We haven't seen any. We sent that information to DOH. We sent it to other payers, when they have to do HEDIS reporting and things like that. I kind of like to see, how much it impacts, the exchange. But it's not to say that we should stop. But when I look at the LOINC.org, actually there's a slate of 2,000 most common samples of the most common ones that they have, that they had recommended us to look at. And when I looked at that, a lot of them we have already, the top ones we have already included. I am pretty sure that there are probably another 200 that we could do that might close the gap a lot more tighter than what we have now. But I don't think that we'll ever get to 100%. It's not going to happen. I just can't see, from an operations standpoint, and a resource standpoint, that it's realistic to shoot for 100%. And I haven't seen actually the Meaningful Use 2 saying anything about the percentage.
No. So for Meaningful Use Stage 2, for both the eligible provider and eligible hospitals, there are criteria. And Jeff, do you have the information handy? No, but okay. I think for the provider, it's like 55% of the tests that they need to receive electronically into the EHR system, and that when whatever they receive also need to be like compliant with line mapping. I have that document somewhere on my computer. And then of course the electronic lab reporting is another criteria that they have to be mapped to line, and that one is basically 100%, right? I mean, 100% of the electronic lab reporting should be should be mapped to loin. So there are some of those drivers, and of course there are rumors out there, and I have to make sure I really say that there are rumors out there that that CMS may at some point require that the claims be submitted along with the CPT, the ICD-10. Along with that, they would expect loin to be part of that claim submission. I mean, again,
that was a long time ago. They talked about the loin being an audit portion of claims like 5 years ago.
I think nationally, as Ray said, it came up several years ago and continues to be on CMS's mind. But from a national standpoint, none of the labs feel it's appropriate or are looking to basically submit with their claim results, which is what basically CMS wanted, in some dream of theirs. So you submit the claim for the test, and you also send them the result. And I don't think...
Well, there may be some new drivers, in where the industry is going down this HIE path that, we probably there's a lot more tension, to get at it. But from a reality standpoint, we can work together. I mean, Hawaii has most collaborative, I would say, niche. If you look at everywhere else that we have talked to, we have the most people willingly around the table. First time Francis and I we sat across from each other, then we sat like one seat off, then we sat next to now they're like collaborators. So I mean, the collaboration, is the power, I guess, of this committee. I can't imagine we can work towards if the 55% of what a physician get are the ones that they want to trend. I could see those trendable or trendability will be more powerful if you give them loin. But for any lab results that are not to be trended, what's the loin for? Right? I mean, I can't imagine, so if we could map things that might have a loinable kind of a nature to it and put our emphasis on those, I think that will make a long ways rather than having to just do a shotgun approach to, reaching at the bottom.
So on this slide, I did pull out the slide from the deck, and then, like one of the lofty goal that we started off with was to strive for community agreement on loin. So no problem, first 25, we're 100% matched, right? And then when we get to the top 100, the percentage went down to 70%. And then as we finished the top 400 between the two labs, and also included Kaiser and VA in the mix, the match get to 40 to 45%. I mean, the same test based on description, the loin that was chosen by different labs became 40 to 45% because there is, I guess, two opposing forces tugging at each other. On the one hand, as a community, we want to use the most generic code applicable. But then when you look at the different references, when you look at the manufacturer recommended, they try to be as specific as possible. So somewhere between the most generic to the most specific, that's the result, especially when you get to the more esoteric tests, that is, then we went down to maybe 40 to 45%, and of course, it's top 400 tests is probably account for over, I would say, 95% of volume, maybe if not more, right? So,
well, where we are actually trying to work towards is a common set of loin, so we can all be able to report the same loin using whether it's a lower or highest denominator.
Right.
Now, where ONC or CMS is asking, for example, for us to loin our records, it could be easily done where we have our own silo. We just apply, and where everything gets exchanged into a common database or common traversing entity, you don't really have those kind of cooperation, like what we're trying to do here to pick one common one so that the providers can be able to make sense out of that.
Right.
There is no really logistics within the HIE, nor I would say any EMRs to be able to say this LOINC and that LOINC are associated, right, even if they're the same test of different LOINC values. So, on the one hand, doing everything is probably impossible anyway. But if you say that, okay, why don't we, each lab works at getting 80% of their in conjunction with each other, that's going to take a long time. Because, to have to do your own, sit down and compare 10 or 20 labs and try to map out the most common ones and see where the exceptions are and try to coerce the finite lab to say, hey, why don't you follow this course? It's not going to be easy or not even impossible.
Well, that's why I didn't even suggest that when I did some of that comparison, some of that analysis, and it was very obvious that the testing method and perhaps the instrumentation and everything is so different, because those that are, when you get beyond the top 200, they become esoteric tests, and it would be unreasonable to expect that everybody can agree because of the way, that's the nature of it. Like DLS is specializing in some proteomic testing for that test, whereas like some other labs may be using just the older methods so you can't really force them into the same bucket when it's totally different, right?
And I think the other thing is, even though we strive towards being the generic, sometimes just the units of measure are different.
Yeah.
So you cannot use the same. So if we're striving to get the same LOINC across all the institutions, that's not possible. Yeah. So I think what you're saying is true. As we do more and more, then the variance goes up.
Yeah, we try to use the VA list.
Yeah, we did.
And it kind of sways. Sometimes it's generic, sometimes it's special. It wasn't like, we didn't really know the logistics that they used to apply. We turned out to, actually we farm it out to a consultant who helped us actually do a special review of what we're doing, and then actually try to apply, some pretty accurate code to some of the additional ones that we did. It's getting harder and harder. That's why I recruited my special, task force. The SWAT team over here. Susan, she, because IT, although we did have lab background, didn't really get into the situation where now you're doing PCR, you're doing special testing for different tests. We don't know. We're lost already. We can say CBC, hemoglobin, they're all the same. Hematocrit, they're all the same. But when it comes down to the very minute, aspect of how to determine a point, we're lost.
But you should didn't talk to Raleigh together, because I found out that CLH ended up, because IT was trying to do that, but at the point where they hit maybe about 400, then they realized, okay, it's probably better done by the lab experts. And that's what they started to do. So I guess you guys came to the same conclusion then.
I think Francis, your point's well taken. You don't need a LOINC code for serum mayonnaise or some esoteric test that just was developed. The tests that doctors want to trend are like, glucose, BUN, hemoglobin A1C, those are the tests, right? And again, I've been out of the field for a few years, but I still believe that, those top 100, which probably amount to 80% of the tests, and again, micro is in another realm of its own, there probably is a common code for most of them, but, just depends how they're going to use it. Because like Ray says, it doesn't do any good if everybody has their own unique LOINC. you'll never be able to see any trending on some kind of graph system if everybody's using different numbers. I mean, so.
Okay, so I guess from the task force perspective, would we want to just basically draw the line somewhere and say, okay, this is going to be the way that we're going to, as a community, generally agree to? Where the noise coming from?
So when I looked at the 2000 code, just on a high level, there could be some opportunities to identify maybe another 100 first. You know, I think we can munch on 100 at a time and try to see where we end up and you know, how esoteric, the degree of esoteric, you know, level of esoteric, you know, test that we might hit at that point and call it quit at some point. I really, until they say, hey, you got to do 100%, I need the TA to come down and tell me, how do I launch a test, the word comment? What's a comment code for launch? You know,
I think this is the same category as what we were talking about before. Again, I don't think our discussion here is so unique compared to other states. So, you know, I mean, if we kind of chip away at it a few hundred at a time, and then see what, you know, the rest of the country is doing. You know, what's Utah doing? What's New York or California doing? You know, they have as bigger problem than we have, right? So.
Well, okay, so
CDC.
So putting my ONC advocate hat on, because they do pay my salary.
The next
for the next few months. I think the ideal, again, as when you have a standard, you want it to be adhered to, and they want to have that adopted. So when they say that they want the line to be this, to be the code that will be used for interoperability. So that's the driving force, right? I mean, again, how meaningful is it if you have like a one-off test opposed to the one that is trendable? Then you don't really need that one-off test that is done maybe once every 5 years to be line mapped. But I guess the ideal is that if you have a standard, you have a standard, and to a degree possible, you want that standard to be enforced and be adopted. So from that regard, I would say I would encourage that, yeah, I mean, the strategy is, whatever the strategy is, it may take 2 years, 3 years, or maybe meaningful use stage 3 require that 95% of the test exchange has to be launched, and then we will get there, right, in 2 to 3 years. So I would say what we've talked about makes sense, but at the same time, I think I would strongly encourage everybody to continue the line mapping effort so that we can basically adhere to that standard. Okay, so that's my ONC hat, advocate hat. Okay, so I've done my duty, right?
They won't be paying your salary by the time we're ready to It's only not a year on the funding, right?
Yeah, right. Yeah.
He'll be free to do the line count.
You have too much time left.
So let's see, it's 7 o'clock, and again, thank you everybody for taking time after work to attend this meeting. I hope the information that we have shared today is useful. And do we want to have another meeting for another set of discussion, or do we want to, like, you know, convene a meeting as we find the need to do so? I mean, because like last year we had a meeting and then we launched a project, and then everybody basically went back and did their own project. And then now there is the ELR reporting side, and I don't know whether we want to perhaps do a follow-up in a few months to see where we are at. And because, everybody knows, right, because we are trying to work with Department of Health. HHIE is trying to work with Department of Health to be designated the agent to support the electronic lab reporting effort. So that perhaps it's one of the useful thing for us to meet when we get closer to the point, because we're going to be meeting with the Director of Health next week to finalize the agreement. If we can finalize the agreement, that's great, but at least to take the next step on that agreement. So do we want to perhaps plan a meeting for 3 months or schedule it later, or how do you want to do that? And the next topic.
Wait until you're ready for the meeting. You know,
okay, and then
delay, yeah.
Okay.
And even like new information this summer, whether it's August or September, like what Ray said, or maybe Susan Knock will get some new information that will help clarify some of the clear issues. It might be a good time to pull the group together too.
Okay. All right. That'll work. And I would again encourage you, if you already have the additional line mapping done, that I'd be glad to receive it as like a repository that we have in the Health Information Exchange, because like Kaiser said, they don't want it to be distributed to everybody, their list, but and I guess everybody wanted their list to be somewhat proprietary, but I would like to be the one, if possible, if you don't mind, for HIE to hold that data, because we may be able to help with the translation or other purposes. Supporting Department of Health, supporting whatever efforts.
Yeah. We actually have the list of lines that we know what the next common ones are. So from the other standpoint, we look at maybe doing 50 or 100 at a time, and then we'll pass it to you for your distribution or your review. But I also like to kind of talk to Aldine about where CLMA-HHIE is, and we might have a lot to learn about SNOMED as well from Aldine. You're already reporting that.
No, we're working on it.
Oh, you're working
on it.
Okay.
So what I got from the discussion here is Keith had already sent us the SNOMED, and we are trying, well, I am trying to get HHIE to actually be CLMA-HHHIE's consultant. And then what we want to do is to work through all the meaningful use things that we have to do at the hospital, and then use that, and as long as everything is okay with the administration, then I can bring those kind of things to the table and share it with other people on the kind of things that we had to go through. I was happy to hear that Keith actually sent his list to CDC, because that's a really good thing. If once we can get that, then applying that would be much easier. My microbiologist knew nothing about Line Course, SNOMED, or anything, and I just used the link.org education to try to make sure that everybody was up to snuff on that. And then on our, we have a tool from our LIS, and we did it in the mock environment, and we just played so that we could use the tool. But now we're at a place where we'd have to put it in prod, and I don't want to put something in prod that's nonsense. So, we're kind of like at this crossroads. So all the paperwork went up to administration. I'm just waiting to see when that'll be signed. And it seems like they understand that I need help. But I can't do it alone. So
I think the more things we can do as a community, and as long as it's not a proprietary kind of issue, kind of sharing resources. Whether it's HIPAA or Y2K or some of those other past potential catastrophes, the community came together and came up with and shared the burden in putting together procedures and whatever. That way it was cost savings for everybody. So, we can kind of work towards the same goal together and share information to help each other out.
And I really am an advocate for all of us trying to use similar pathways, because it's hard to stand there alone. So I can't see why we would choose to do that if there's all these other people who are trying to do the same thing.
Exactly.
Thank you. One other thing related to electronic lab reporting, the interface. Kaiser, Akiyama asked whether there is a standard set of specs that the Department of Health can provide for the documentation purpose.
Talking about what kind of specs?
Like the data, the actual within for the HR7, the different message types, the different pieces in that message. Are there any specification that you want the different labs to adhere to? I guess that's the question.
Well, we don't really have one currently on hand. The most current documentation on HL7251. And the ones that we do have, like I was telling Lynette, is based in our integration engine. And it's very difficult for us to export that out and for the common person to look at it because it's basic. It has a lot of mapping involved, so you would have to read through all the specs to see it. On that LIC website, there is an HL7 thing that you can download and request for it, so the most current version. I would think that would be the best bet for now. Okay. It tells you what is required, what kind of data types they recommend, what kind of validation tools they need.
Okay.
But at this time, we don't have a current 2002. I didn't want to pass our older version when I know it had changed.
All right. Thank you, everybody. And thank you for the good meeting. Thank you. And we'll meet again in 2 months.
Thank you.
Bye.
Bye.
Thank you.
Bye, Susan. Thank you. And I'll let you go.
Yeah, I didn't know she was going to Maui. Yeah, I saw her last night at the meeting. Yeah.